Good morning. This is Essence of Medicine, and today we are going to share some stories from spine surgeon. I'm Dr. Abbasi for Essence, and I have a very special guest, Dr. Sharma. Please introduce yourself.
My name is Dr. Devashish Sharma. I originally hail from the north of India, and I'm an orthopedic spine surgeon who specializes to do only spine.
Well, how long have you been a spine surgeon, Dr. Sharma?
So I started in 2012, so you can say 12 years.
12 years. Now,
Uh,
now, obviously, as a spine surgeon, we deal with the problems of the spine, which is not a rare condition. It
yes.
is, as a matter of fact, we have some studies that show by the time you are 50 years old, there's only 25% chance that you don't have spine problem. By the time you are 60 years old, there's only 5% chance you don't have spine problem. By the time you are 70 years old, there is 1 to 2% chance you don't have spine problem. Obviously, not all of them need surgery. Not all of them need your service. How many of them we deal with other means like physical therapy, injection, and so on. But the numbers of the instrumented spine surgery in 2022 United States has been 1.62 million according to Baker Spine. So this is a very common problem. So if you are a person, if you are a human, you have a spine. So I think this podcast is going to be have some good information for you. Now, tell me what in India, what path do you go through to become a spine surgeon?
Very interesting. So, in India, so as I think pan world, they have two guys. So the orthopedics guy trying to do spine and the neuro guy doing spine. Both of them are trained to do spine. And then in India, we have some guys who specializes into doing spine, either or from orthopedics or from spine, who go into different fellowships. And beautifully recently, relatively recently, I think 4 or 5 years back, they started a beautiful program which is MCH spine. It's like super specialty into spine. So you just treat spine, but all of it, like the intradural, the extradural, the tumors, but that's like very restricted. So there are a handful of guys who would do all including spine, but then primarily neuro and ortho guys doing spine. So that ways.
Well, and as well in the United States, you can go from both direction, and meaning from orthopedic or from neurosurgery to get to the spine. And it has been an eternal kind of thing. People asking which one is better, neuro, ortho. You're ortho, I'm neuro. We are going to have a friendly contest here. Is any of them better?
I would say so that's a very interesting question I tried to answer last year
Uh-huh.
in my podcast that whom should you get operated with?
Mhm.
I would say the guy, so let's look into the specific surgery. If, say, for example, you need a two-level fusion, so the guy, I would rather trust the guy who has done X number of fusions for X number of years regularly. Regardless, he's done what? It's the practice which matters, not the designation.
Perfectly said. Perfectly said. And I answered that the same way to my patient that, once they are few years into what they do, no matter what direction they come, they're all equally good. And it's about specific procedure. Like for somebody that who has done certain procedure hundreds and hundreds of time, it doesn't really matter what direction they go from. And you said as well there is now new consideration to create a path just for the spine. And I totally welcome that. And I'm going to tell you why. Obviously, it is the fact that when we come from neurosurgery or from orthopedic surgery, our focus of education is different. In orthopedic surgery, your focus of education is dealing with bone structure. And in the neurosurgery, our focus of training is actually nerves and how deal with that. So I can just tell you, in some cases, that we neurosurgeon learn to do removal of bone because our focus of attention is the nerve. We are so extraordinary careful. Like I'm talking about the facetectomy that I learned from my teachers that use a high-speed drill and you brush the facet layer by layer to remove it, and that takes 15 minutes. So I was flabbergasted when my orthopedic colleague took an osteotome with the
And
tap
just,
tap
yeah,
tap.
and banged it off. Yes, yes.
So this is my first story from spine. When we did our first fusion, TLF, when I was a resident, one level fusion, it was 7 hour surgery for the reason I just told you. So,
Yes.
so what that means is that you come with a tool set, and I think if I have any suggestion for the resident is that go to other discipline, add to your tool set, because you will be amazed how much more efficient you can be if you just look beyond your immediate field. So tell me about your residency. When did you start? How did you start? What did you go through to become an orthopedic surgeon?
So I started my graduation, or we call it MBBS, like medical graduation. I did it from Dehradun. It's a beautiful, beautiful old town in the foothills of Himalayas. One day you should visit that place. It's like actual foothills too, and it was so beautiful that that became the retiring place for British colonials. So they would make beautiful mentions, and since it was the colony, they would retire there because that was almost like the balcony from where you could actually peep into Himalayas, at least in those days. It was very beautiful. So there I did my med school, and then I did orthopedics from Delhi, nearby Delhi. And then I did my fellowship in spine surgery from UK, London.
Mhm.
That was, and then I did endoscopic spine from Germany. That was a short fellowship, but it was quite exhaustive for doing an endoscopy. And then I had small stint working in NYP, New York Presbyterian, under Dr. Roger Hartle.
That's a long path to get where you are now. But I tell to my patient as well that yeah, it was a long path for me to get there. But honestly, did you want anybody who has less education to work on your spine and so on? And you told me just before we started that something about this aura about spine surgery in India. Do you want to elaborate on that a little more?
Would you say it again?
This aura, this this feeling that patient and your India society has about spine surgery.
Yeah, yeah, yeah. The interesting word would be the taboo. So the reason we started doing podcast when I came back to India from my fellowships, India is a very interesting place. It's massively huge, and the thing is that the culture is different. And culture changes in a 2 hour flight. You'll find different clothes, different culture, different language. We have more than 24 official languages
Wow.
and spoken dialects more than 100. It's very interesting.
Hmm.
So, so many cultures bring so many stories. So, primarily, it is said in India that if you go to the village of India, that okay, you have a knee problem, get a knee replacement. You have a fracture, you get it fixed. You have whatever, get everything done, but spine surgery. That's something should not be done, should not be attempted, because the moment you get it done, you get paralyzed.
Okay.
And that's like a serious affair. Like I can tell you, you sit in the OPD, and every day today, I would have to answer this question 5 times in a row. That all my seniors are saying no to the surgery. I don't, and they're saying you'll get paralyzed. You won't be. You're right now. You're doing 10 steps. You'll be on the wheelchair. So how do I
So
trust you, doc?
now, truthfully, even in United States, spinal surgery, especially fusion, has a bad reputation. Where do you think it's come from?
I have a thought about it. 90s, at least I'm talking India, 90s, they started putting up high resolution MRs. Not real high resolution, but at least something in which you would actually be able to see the T2 image, right? Before that, you had claudications. And they would just do a myelogram and try to do some kind of laminectomy or fusion, which would sometimes go right and sometimes obviously go wrong. See, if you have a listhesis, should you do a decompression, it's a disaster.
Yeah, and yes, in 1990s we start doing more and more fusions, and obviously people are scared of spine surgery, scared of the fusion, because some of the results weren't good. As a matter of fact, if you remember, about 5, 6 years ago, there was a big multicentral study that it was part of it was in Europe, in Scandinavia, part of it was United States, about the outcome of spinal fusion. Are you familiar with that study by any chance? So
Yeah.
the results weren't
The
very
long-term outcome of fusion. Yes.
yes, the result weren't was not good. What do you remember about that study?
I think it was like that the amount of satisfaction rate after spinal fusion of after X number of years was kind of is comparable to the people who did not got fusion. I think something was like that, if I would remember it correctly.
37 to 40% favorable
Okay.
outcome. But
Yeah. See,
but
that's the problem of the world. When the studies are at multicentric places, the indications of surgery change.
correct.
And so some fusions, properly done, properly indicated, change the life, as
Yes.
we every day see in the practice.
Mhm.
And some fusions just create a massive mess. I think I would say the culprit would not be even the doctor who operated. I would say the culprit would be the amount of training needed to be put in to actually see not only the fusions, how to do it, but to see the outcomes of those fusions.
Yeah. Now, the reality of that is that according to that study, if you operate on 10 patients, 6 of them will be unhappy with you. I can just tell you, I have done like 5,000 spinal surgeries. If from that 5,000 spinal surgery, 3,000 of them were unhappy with me, that would be 60%. You can imagine, I wouldn't be a surgeon anymore.
Nay, we would be doing this talk, but there'll be some more bars over here.
So
right?
there are some critique about that study. What did you really measure?
No, that's what I'm saying. Actually, the problem is, sir, that the real, that's what, I saw you in the practice, you would spend a serious amount of time talking and assessing that, is it really the axial pain? Is it really the pain of instability? Nowadays, the problem is when you stop asking questions.
Yeah.
When you stop asking, do you feel that stiffness when you get up in the morning? If you don't ask right questions, you get the diagnosis wrong, and then this 6 out of 10 story comes up. Yes. Otherwise, you would remember on your hands that how many patients are really unhappy. There would be numbers on the fingers, right? Not really.
You remember them personally.
Yes, you have that. Sometimes in India they have my number, because it's impossible, because it doesn't happen. It never happens, actually, to be very frank.
And I'm just thinking about that study. Who are you guys? I mean, what did you do? How comes in your study that it seems to be a valid study? What are you doing different? Because we are practicing here among lots of private practitioners and so on. And then I go and look at them. Every single unhappy patient calls you 200 times. They come to your office. Imagine 6 out of 10 patients that you do surgery, they come to your office unhappy. They call, they're unhappy. There is no way a practice could be maintained if your result is only you're helping 4 out of 10 patients.
I'm telling you, Dr. Basi, it is true for us, but it is 10 times, because I've seen you guys working, and I've been to US multiple times. I've seen you guys working. It is 10 times more difficult to actually maintain a good reputation as a spine surgeon in the US. Things are so complex. The medical legal is so complex. a small, small things need to be taken care into. Patient feedbacks are very important. Scores are very important. In India, things are relatively easy. So for you to do these kind of fusions and the kind of results you deliver are
Mhm.
actually beautiful. And I think the whole reason is not even the technique, but the clinical acumen you would possess.
Yes, yes.
Who
Now,
needs fusion?
this is about stories about spine surgery. So why
Yeah.
don't you tell me your most memorable patient that one good, one bad, experience, and
Yeah.
I'm going to do the same. Let's start with the good one.
Okay, that's interesting. One interesting case, I had a lady, hails down from Punjab district. She comes to me, and the first time she comes to me, she tells me, "I've got five spine surgeries done, and the claudication is persisting. And now, since they've operated me from everywhere, I think the D12 to S1 was done finally at the last trial, but the lady has L4 numbness. Uh, First decompression, then repeat decompression, then small fusion, then extension, and finally D12 to S1 has already been done. The lady has weakness, and a cage has backed out.
Hmm.
And there's a cage back out, and the primary surgeon now, the guy, so two different surgeons operated, and the last guy did the last three surgeries. This guy has finally put his foot down. He says, it's a cage back out and such a big construct. I don't even think that trying to throw the cage back in is a very risky affair. So, can you do anything? And I'm looking at the case and it's just wondering what I'm supposed to do. We did all the tests, we did CTs and everything, and I actually saw a cage backing out and hitting the L4 nerve. So, luckily, the cage was made up of PEEK. To make it simple for our viewers, it was plastic.
Plastic, yes.
So what I did, I threw in my endoscope to the transforaminal hole, fired up the burr, and actually shaved off the plastic itself and then in some of the metal with the burr, which was like almost a trial, but it worked. And it was almost like magic. The patient starts getting recovery in the sixth surgery. I have not operated. In your country, it's easy to actually find people who have done 5, 6 surgeries and they come. For us, it's a big deal. That yes, yes. But then it was a beautiful, good story.
Yeah. And I think that my best moment is that from the spine surgery is that I had this patient literally over 500 pounds.
Oh my God.
The way I do the surgery with the transcaminolef, the weight is not as big of a factor like in regular surgery. Whereas, regular surgeries, our societies say don't do surgery on BMI above 40. And for some people, even BMI above 35 is an issue because you have to work through more tissue. I saw this young man who came to me, found me online. He's like 35 years old. He had already multiple decompression, and he went to Cleveland Clinic, and the panel looked at him and said, you need a surgery, but you need to lose 100 pounds, 150 pounds before we can do a fusion. For a good
My
reason.
God.
They're a good surgeon. They understand risk versus benefit doing this kind of surgery on somebody
Yeah.
like 400 pounds. Now, a year and a half later, obviously, this guy didn't lose 150 pounds. He gained another 100 pounds because he cannot walk, he cannot do anything. Only thing he can is sit on a couch and eat even more. The only thing left for him. He found me, and we are scheduling him in our regular hospital, and everybody's calling me. Everybody's calling me that, are you crazy? What are you doing? Why are you doing surgery? And by that time, we already have published paper that we show we realistically can do this surgery. And I'm showing them the data and so on. And but I have to be critical to our own profession. Everybody wants to do surgery on healthy patient. Everybody
Yeah.
wants to do take care of easy cases.
Yeah.
As a matter of fact, sometimes we say, in the closet, in the lounges and so on, we say, I don't want to have that on my record. Because we know taking care of difficult cases, you have higher complication rate, and then it's your reputation at stake.
Yes.
And
Yes.
sometimes we decide not to take the risk for the patient. Sometimes when we tell the patient surgery is not safe, but what we don't tell the patient, sometimes some surgery mean it's not safe for my practice because
Very true. It's a very serious thing to know. We have a major problem in many of the countries like yours that a surgeon, trust me, I'm sorry, I'm interrupting you, but it's
no,
try to
please
read
go ahead.
between the line, try to read between the lines. What Dr. Abbasi is saying that sometimes a good surgeon with actually having the required set could have done a good job, but because the medical legal is so complex that it becomes an affair, and actually he has to turn down a patient because actually it can backfire.
Yeah. Now, the reality is we talked to one of the biggest insurance company in the United States. It's called Blue Cross Blue Shield. When we show them our data and so on, they were fully in agreement with us that no, this patient, when they cannot walk for whatever reason, like they're big, and they have spine problem, they have pain, within 6 months to a year, they develop cardiovascular problems, and then all of a sudden, they die on the cardiovascular issue. So when we say not doing surgery, it has a risk for the patient, but not for the spine surgeon. So we dismiss that often, that when we say it's not safe, we just are shifting the risk of the spine surgery to patient dying of cardiovascular event 6 months, a year later, because our body is made to walk, and if we don't, it decondition very rapidly. Now, this patient, I really had to fight for this patient. Now, I imagine the whole hospital, the whole medical staff is looking at me like, we really don't want to do this. We don't have a bed that can carry 500 pounds, but which is not true. The Jackson table can carry up to 650 pounds and so on. But you see sometimes that or anesthesiologists and say, this patient, what are you going to do? This patient is not going to wake up. And I'm trying to tell them, this is not going to be your usual 12-hour surgery that you're right, patient wouldn't wake up. This is like going to be a 2-hour surgery. What? You're going to do a 2-level fusion in 2 hours? I don't believe you, and so on. So I had to transfer that patient to the university here. And thankfully, I could find people who helped me with that. Lo and behold, that patient, even though our surgery was literally 1 hour and 52 minutes, even after that less than 2 hour surgery, we had to keep him intubated over the night because of his lung. Now imagine, so they are not wrong. After 12-hour surgery, the lung wouldn't recover anymore. But next day he was extubated. For first time in 6 months he walked. 2 days after the surgery he was discharged, and 4 days after surgery he flew back to Cleveland. I had it actually on YouTube. I have a interview with the patient and the family, and the mother is crying because for the first time in a year or so, he sees his son being able to walk and take care of himself, and that is was very emotionally heavy for me. That what we do has really impact on people's life. It is not just a theoretical thing. It's not a statistic. And every time I have to fight for a patient, I am reminded of that patient that
Yeah.
we have to fight. And now, and that is, I think, what I learned during my career. I learned from people who are in this for the right reason and are willing to fight for the patient, are willing to take the risk for the patient. Imagine if anything would have gone wrong where everybody tells me I should not take care of that patient. Imagine if
Yeah.
anything goes wrong.
Yeah.
They're all going to point finger at me that we told you so. But that patient within a year gained another 100 pounds because he couldn't walk.
Yeah.
Now they continue that trend and see what is the life expectancy of that young man that is just has practically nothing left for him. He cannot move. And nobody disputed that he needs surgery. It was just that who is willing to take a risk for the patient. So this was for me one of the highlights of my career.
Beautiful. Very beautiful. very beautiful and very inspiring,
Thank you.
very
Thank you. But we have as well, um, cases that we really grind us down. And I want to know one of your bad stories, one of your, I would say, stories um, that is not positive. What
yeah.
do you have in mind?
Yeah, it's a beautiful thing. As a surgeon, I think you must have also felt that you may have had wonderful, great stories, and they take backseat after a while.
Mhm.
But as you were talking about some of the videos before we started the podcast, that bad stays, gets viral. Why? Because it's a human psyche. Very similarly, in the surgeon's life, also the patients, the complications stays with you, and I think it's okay. That's the learning curve. It stays with you, and you learn. I started practice, and like the initial days of my practice, we have become a spine surgeon, and as a orthopedic spine surgeon, scoliosis is your forte. You do scoliosis, right? So, and India, as you already know, attracts patients from 22 different countries nearby
Mhm.
because of low priced, high quality treatment. We have a very, very high quality, sometimes at par with US and UK, almost similar setups,
And
but
I
the
can
price.
attest to that. I can
Yes,
absolutely attest to that since I have been there so
yeah.
many times.
Yes. So the price and the price is 1/10. So we have a lot of patients flying in from different parts of the world, and there's a beautiful patient. A girl comes down from, I think, Iraq, with a scoliotic curve of something around 55 degrees or something like that, and a little bit of surge. The curve starts in cervical area, and one of the lungs have collapsed, and or like it's been collapsed for a while now.
Mhm.
And me and my those days I has to report to one of my senior doctors, and then we as a team decide that no big problem, we are going to just put in the screws and make it straight. And I remember the girl, we do the surgery, and a flat 6 hour surgery, uh, all the curve gone, almost reduced to straight spine,
Excellent.
looks perfect, beautiful, neuro monitoring intact, all is well. The real problem starts 3 days after the surgery, that the girl is not able to properly breathe. So the SpO2 falls, the oxygen saturation keep on falling. So she would require frequent reintubations, continues like that for a month, second month, finally tracheostomy is done. And at that time, the patient, since the patient has come out from different country, and though it's relatively cheaper from the other world, but still you have a bigger set of hospitals there. 2 months later, the money is exhausted. So the guy flies back with her daughter and the mother back to Iran, and they try to manage it in a smaller hospital over there. Things don't work well. They arrange some more money, come back to us the second time. They had a lot of faith in us, and they stayed with us again for 2 months. A lot of money put in, and all we are doing is doing the respiratory management. We are just the secondary consultants. They're doing managing.
What was the
But
problem with the respiratory
yes, so
situation?
exactly. The problem is, since we have expanded the second lung, it never became properly all right. The secretions kept on, it never got properly expanded. It was a forcible expansion of the lung, which never got expanded. The secretions never stopped. The second time she comes, loses all money, goes back again home. Third time she comes, the same thing happened. And after they'll go back again, and then we finally hear the news that one day she's no more.
Oh my. Oh yeah, very tragic. You see, that scoliosis, this is what I understand. It happens over so many years. Your body adjusts to a set of anatomical changes.
Yes.
And when you correct that, you correct one part, but the other part cannot catch up. That is very tragic.
Yeah.
Well, and you see that there, you that story will live with you forever.
Yes, yes. I could not remember. I've never saw her dying, but I couldn't remember that beautiful girl's face. She was a teenager,
Yeah.
and I think you will always keep on contemplating that making it beautifully straight was the worst thing we did.
Yeah, yeah. Well, we have a saying in United States that so it's not wouldn't be completely appropriate here, but we say surgery is just one part of the thing that we do because
Yeah.
the patient is made more of only the part that we do surgery on.
Yeah.
And sometimes even though surgery is successful by itself, um the aftercare and what comes after, um and I can very sympathize with you, the emotional toll it takes on you when you try to help people but then you're not successful. Now my
Your turn.
my tragic story is that I have this couple that come actually from Arizona, and she has a grade 2 bordering grade T L5S1 spondylolisthesis, and she has a lots of other medical problems. So local doctors are not willing to do surgery for a good reason. It makes sense. So, but they are very active. They look online and they are coming to me for you know additional consultation. And as you know, in a grade 2, grade 3 spondylolisthesis, the dura, the skin around the nerves, is stretched. The
Oh,
nerves
yes.
themselves stretched, and
Yes.
so on. And this patient is elderly, about 80-year-old, and is not in the very best condition. And
Oh,
to my best, ability, I explained to them this is not an easy case because if it was easy, you wouldn't come to me. You would take care of it in Arizona. I explained to them, the risk profile and so on. And we do the surgery. The surgery actually goes exactly what you said. That is the thing. Technically goes perfect. And
yeah.
but after and we do a in a grade 2 spondylolisthesis L5S1, I always go above and below, meaning that
Yeah.
go do
Yeah.
I do L4 to S1 fusion because I want the construct breach that bad
Yes.
segment completely.
Absolutely. Absolutely.
And I get a CAT scan again, like you. Everything is good.
Yeah.
That is, you're dealing now with a bordering grade 1, grade 2 spondylolisthesis, but she has immediate foot drop. But more than that, she just cannot walk, and patient is obviously discharged right away. Initially doing for a few weeks well, but then loses completely ability to walk, and then EMG MCV shows that she is not only, yes, patient does have a L5 nerve root palsy, but it has actually L2, 3, 4 palsy, which I cannot explain because I just did the surgery on L4, 5S1. And over the neck, that happened about a year ago. And in the last year, I get always this truly polite but angry emails and conversation, mostly with patient's husband, and then that I didn't meet their expectation, and that's the worst for us when we are trying to help somebody but we cannot deliver what we are expecting. Now the patient has additionally to the surgery, after surgery, has a blood clot in the legs, and then has pulmonary embolism. She has been recovering from that, and she barely started walking just about 4 or 5 months ago, and now it's becoming more and more independent. But I'm just thinking about the disappointment in the patient that you're trying to help them, and statistic catches up with you, because even though you tell the patient, okay, it's all about statistic, I cannot guarantee a good result. In truth, that is what they're expecting from you. They're expecting from you perfect.
Very, very serious stuff.
Yeah. And
Whatever you say, whatever you tell them, they are here for a good result. That's a bigger, complex situation. That you can tell them that if you ask yesterday, I put up some patient for a transfemoral block, and she's got every possible disease in this universe.
wow.
And I told her that I take you to the OT, you're going to die. And the whole family is like very sweet. Okay, no problem. If even if she's very old, even if she's like, yeah, yeah, till the time you say it and she's alive, it sounds very interesting. But the moment the man is dead, not only you, we also mourn and we feel really, really bad. And that's what stops us from doing something very complex. Yeah.
No, what I think many people, but as well society, even though they understand what we do is statistic, you cannot guarantee good result for every patient. And
Yes.
and the best way, one of my teachers used to say, the best way not to have complication is not to do surgery.
Yeah. Yeah.
Um, and as a matter of fact, one of my very revered teacher used to say, if you haven't every complication on the book, you haven't have done it enough.
Very true.
So
There's a beautiful line in a book called, you must have gone through it someday in your medical graduation, Robbins Pathology.
mhm.
The chapter Neoplasm starts by saying that there's a definite way to actually not have a cancer. That is not to be born.
Yes. Good one. No, and I'm absolutely with you that if we put a high price that make the surgeon risk averse, that's going to actually backfire by us not taking care of sick patient. Then
Yeah.
then why go to medicine if you are not going to take care of very sick people? And that is, I think, one of the. I'm not sure if burnout is a phenomenon in India yet, but
Uh,
burnout, I'd say that
Interestingly
here.
speaking, not much, except in training. Except in training. Trust me, a very, very different way of saying it. I'm not sure what the US audience, especially US doctors, would think. I have worked in UK, I have worked in Germany, I have worked in Austria, I have worked in Tanzania, I have worked in Kenya, I have worked in a little bit in the US. Trust me, it's the easiest in India. Uh, the work hours are comfortable, and relatively the medical legal is not that complex, and that's the reason the scoliosis would fly down. That's the reason people from different parts of the world will come down, because the surgeon is not frightened uh, to some extent. To obviously there is a law which governs, and it's a very significant law, but at least to not to the point of that you're actually see, once you start fearing about your own skin, the quality of good work, uh, especially in the complex case suffers. So Abbasi may be extremely good surgeon, but if he starts worrying too much about himself, maybe 10 of the better cases would just slip off. Why? Because he's afraid.
Yes, and I think the one of the things is, and I want to use that as an introduction to watch a video that has gone viral here, is amount of the stress or uh, what is in the mind of a surgeon who is about to do a surgery, and no matter where, I think in India or here or anywhere else, when we enter the OR, we are in a different world. We are in a trance. We are concentrated of doing a procedure that is now life and death. Can be the difference between life and death, and everything that take your attention away from that is going to actually make the quality of your work less. What does that mean? When you enter the room, you should be only thinking about how can I help this patient. Whereas if you are thinking about how is my colleague, how is the hospital administrator, how is the lawyer, how are the lawyers going to think about that, and so on. Every time you take your mind away from that, you're reducing the quality of the work. And they have done some studies that they show that they measure the steroid level in the blood of surgeon before and after. Almost every surgery, it is like you have an accident, car accident. It's comparable. If you measure the stress level of a surgeon, we don't show it always, but they have done those studies. If you measure the steroid stress level hormone in the blood of a surgeon before and after the surgery, and it very much resembles to have a stress level of somebody who just had a car accident. And now imagine you have 3 4 car accident or that level of stress every day. year after year. No, we learn to cope with it. But and only surgeon can really think about that in those terms, that what it means being 100% focused on something. And they expect us sometimes, uh, perform in a way that really resembles the reality. Now, I want to actually show a video that has gone viral here in the United States, and I want to ask your opinion about it if you don't mind.
Please.
By the way, this is Dr. Dukmajian. I know him personally. He is an old-fashioned, old-school surgeon. He's an excellent surgeon. I can attest to that. Well, and we know that when we're often old-school surgeon, their interpersonal skills is not necessarily the best. Are you able to see that?
Yeah, sure.
I'm just going to run this 1.5 minute video. I'm just going to be quiet so we can all listen to it.
Yeah.
Where's the section? All right. Here's where you lack intelligence, okay? Do you think I know the sucker's sucking? I do. All right, so 29 years of sucking fluids out of patients with suction. Do you think I know if it's working or not? No, don't talk back to me and listen. I don't give a fuck how long you've been a nurse. Your nursing is shit. You don't know when a sucker is sucking. I do. As a surgeon, I do. Goodbye. Dumbass. Let her go. Fuck her. Stupid bitch. You think a surgeon doesn't know when a sucker is sucking or not? Okay? This is not sucking. It has to be our goodbye. Goodbye. Get out of here. I don't know. I'll know in a few minutes. Okay? But a little suck is not suction. It has to be strong. Okay? When I say it's not working, it doesn't mean it's off. It means it's not sucking hard enough. There's a problem. That dumbass couldn't figure that out. How many times have I told her that?
So I'm just going to unshare this.
Where's the section?
So, first reaction, please go.
Yeah. It's an interesting video, very interesting. I think pan world, anybody who has ever been a surgeon would actually echo with that feeling. The problem in OR is that it's a very high, as you already mentioned, I'm going to use different words to say the same thing for the benefit of the viewer. The problem with OR that it's a highly rehearsed, perfect dance with no mistakes allowed. Nothing should go wrong, and the guy who's actually the director of that nursing that dance is the surgeon himself. Small thing goes wrong, you have a massive trouble. Like this chap, when the bleeding starts, all you don't see any nerves, and when you don't see the nerves, all you chop off is nerves itself. You have a major problem. Sure, agreed, but the other thing would be the reactions can be controlled.
Now,
please.
I can tell you that I have been in a similar situation that, as you said, suction is a basic tool in the OR. Like, I'm a neurosurgeon, I was doing a posterior fossa tumor resection. All of a sudden, my field is full of blood. And if you don't have the visual, then literally patient can bleed out if you cannot see the source of bleeding. And then you can cause tremendous amount of damage. And you're absolutely right. We have been all in this situation. I can say that, certainly, as you said before, it's the reaction and the action and the reaction and the response to that. Certainly, we learn to control it. And certainly, I have never called somebody a bitch or stupid in my war. Internally, I have. I mean, in my mind. I never brought the words out about that. But I'm going to tell you what the problem is with what I see here. Many these social media surgeon, they use this to point the finger to him, say how inappropriate he is because what just happened, and that they're telling that he yelled at the nurse and so on. I honestly didn't hear him yelling. Now, and he starts with having a problem, and he turns into that. It seems that the nurse is truly talking back to him, telling him it's working. Where he's have the suction, he knows it's not working, but then he's totally derailed. I think most of us have been in that situation, and we all control ourselves. We don't say those words loud. We don't, and we understand that if you take your attention away from the problem and not paying attention to the nurse, you are actually making your life harder. The reason we control ourselves is to save the situation, but then after that, put that nurse down and make her understand that when I tell you it's not working, it is not working. Instead of telling me it is working, understand me and how can we fix the problem in the situation, because a patient can die, literally can die, if that problem is not solved. In this case, patient may be paralyzed and so on. I think it was derailed. It started that he was saying that it's not working, but then he was derailed. But have you had any situation like that in the OR? That
I think, Dr. Basi, being a spine surgeon like you and me, I think it's impossible to not have that situation multiple times in your lifetime. Suction is a mess all the time, everywhere, unless and until. So, we have developed ways around it. Like in India, at least in my bigger center, it's a protocol. We have two suctions. One is a main suction, one is a backup. It's just hanging down there.
And today, like I have always two suction on my field. Always, I have two suction on my field.
It is just like it is just like the similar thing. I don't know if you've gone through scuba diving. You've got a main thing, and then is a backup. Things messes up because you can't breathe. You're done. So very similar way. You have the backup suction all the time. Number one, but very truly, sometimes I would say shouting to the nurse, even if the problems are at stake, is not going to solve it.
Now, did you have the feeling that he's loud? He wasn't loud. He was using profanity, but I didn't have the feeling that he's shouting.
No, he actually said he gave a very interesting and straight fact that, after 3 decades, I know what suction is. So if it's working or not working, let it be my discretion, right? Yeah. So, but then it's okay. But then yes, still, I would say, though what I'm advocating is difficult, I would say, and generally surgeons are expected to be very loud. Why? Because they're actually doing the favor to the guy who's lying down on the table, and that's their final duty. And not only surgeon's duty, the whole staff's duty. The team exists because of the guy who's actually been anesthetized on the table. Our existence is because of that patient. So
and that
anything
is
for that patient.
Absolutely. I couldn't agree with you more. And once in a while, we see it in the OR all the time, that there is somebody, scrub tech or circulator or somebody else, they turn the entire OR, make it about themselves. In a OR, like I think the nurse was talking to him, was saying that he don't or she didn't appreciate being talked to like that and so on. So certainly everybody should be respectful, but in the moment patient's spine is open and there's a danger to the patient, it is about getting the job done than the formalities and niceties and so on. All of that can be managed after the surgery.
Absolutely.
When the emotions are low and so on. And but I think, as you said, it's the job of the surgeon to be not only firm, but being loud. OR is not like your couch conversation. Machines are running and so on. You have to be loud, you have to be clear, you have to be so you're heard. As a matter of fact, there is what we call closed loop communication that comes from aviation. That is how it's said. You speak loud, you state what you want to say, the other person repeats that, and then you confirm that. We call it closed loop communication that we have taken from aviation. And there is another thing and so on. I don't know how your ORs are, but in my ORs, we don't talk social talk. We don't have, we concentrate truly on the patient.
Very similar in India.
Yeah.
And we have more liberty, I would say, to actually be serious. And this is almost considered a norm to be a good scrub tech. If you've not listened to lashes, you cannot be a good scrub tech. If you've not heard those sounding words, if you're not almost ready to the point that actually when the surgeon looks at you, you would know what instrument he wants.
Mm-hmm.
It has to be that fast. And that doesn't come in a day. That's a decade-long practice. It comes with a lot of lashes, a lot of understanding. The nerves have to be trained in that system. And that sometimes takes stress, sometimes takes voice, sometimes coaxing, whatever.
Mm-hmm.
And that's all very, very important for the patient. And that's what important. It's patient-centric approach. I remember a very interesting instance. I want to tell you a very nice story. I joined in London as a junior guy, very recent, and I'm like learning to spine. And before that, you're just scrubbing in, and there are everybody, and but there's a culture shift. You suddenly from India to US, India to UK. There's a serious culture shift. So my fellowship in charge comes and tells me after 3 days, Dr. Devashish, you know what? I have a small thing to discuss with you. Please tell me, sir. Like, the staff is telling you're very rude to them. It's like, really, sir? But I didn't really say anything to anybody. It's just been 3 days, and I am like the third assistant on the go. Anyways, how would I say anything to anybody?
Okay.
And then
anybody for the whole world. I know Dr. Sharma personally. Anybody who thinks Dr. Sharma is impolite or rude in any ways doesn't understand anything about interpersonal interaction, because if you go to the Webster dictionary, you word nice, you will see his face next to it.
No, but the best part, so I said, but sir, I really have to improve. Otherwise, my fellowship won't last. It's just 3 days and I've been declared rude. So the guy tells me, okay, I'll get back to you tomorrow. Then he gets back to me tomorrow and tells me, Dr. Devashish, I found out what you did wrong. I said, yeah, please tell me, sir, I really need to improve. That, you asked the instrument to the patient from the nurse. I said, yes, I did. You forgot to say thank you.
Oh my God. Yes. Go ahead. I know where it's going. Go ahead.
And I was like, really? And then I practiced saying thank you to the point that, nowadays in India, if I'm actually operating in a new arm, my subnext, why do you say thank you every time, dude? What's wrong with you? I said, it's a long practice. Shut up in my head from UK.
So see that there, the person who thought you're rude, he thought that surgical theater is about him being appreciated.
Absolutely. But the whole theater exists only because of the patient, nothing else. We are less important people.
And there is a rule that, this kind of actions are not new, that in aviation, mistakes are deadly. Same in the war. So they have created these rules of communication in the aviation. Like when the pilot is giving information or receiving information, they're not thanking each other and so on, because that is an unnecessary word that adds to the volume of communication and actually increase the amount of the mistake can be transmitted.
True.
Like the tower says, the pilot this airplane, go to that runway and wait at that location and then stop. The pilot repeats that and then they correct that and then they move on to fly with 500 souls, and they understand that they appreciate each other. But that is given, it doesn't need to be said. If somebody is so fragile, has such a thing ego, that need to hear the word thank you after every instrument, I'm just wondering what is that person is doing in the OR. Now, one of the things I learned when I go to a new OR, once patients and the family and the whole staff know me, that's not a problem anymore. But when I go to a new OR, I say, listen, I know we're all new here working together and so on. It's all about the patient. I'm extremely appreciative of what you're going to do and helping me to help the patient and so on. But these are the rule of engagement. Okay? I'm going to say you all thank you now because when I'm doing the surgery, I'm just going to do surgery. I'm not going to say please and thank you in the surgery because we have to be concise. And these rules, we didn't invent that. As a matter of fact, in the aviation, there is a rule, they call it the sterile cockpit, meaning that below 10,000 feet, where most of the thing can go wrong, there's a protocol. How you talk in the cockpit, how you don't talk, and there's no social talk, no niceties. It's just communication and information exchange because below 10,000 feet, that is where really bad thing can happen. And guess what? In the OR, you're at below 10,000 feet at all the time. Every moment something can go wrong.
Absolutely, very, very true. These coffee table conversations, thank yous and sorries, would, if not add to anything, would amount to adding the surgical time. I am not interested losing blood. I'm not interested even a one more breath extra on ventilator for my patient.
And we know that has impact on patient outcome. Every additional half an hour adds 17% to the combined risk of the surgery. Now,
Yes.
my question is though, especially in the United States, if you go and look at that, even many surgeons, they look at this video and they're bashing Dr. Dukmajian, say he's an asshole, we would never tolerate that, and so on and so forth. My question is, if you analyze that, is that when he's asking that the suction is not working, and the nurse, instead of looking into what's going on, start back talking to him, then he's derailed. Now, if in this moment something really bad happens, who is going to go and take responsibility for bad thing that happened? Is it going to be the nurse? Is it going to be the manager in the OR? Or is it going to be the surgeon who is going to have to go answer to the family that your loved one is paralyzed because my suction didn't work and my staff couldn't fix it? We don't understand the who is going to bear the consequences of that. And it is just for view of that. I know there are few surgeons here that are big in social media. They're all to get good views. They're bashing him. Now, I will say that I never used, those, those profanities in the OR. There's no place for that. And as a matter of fact, it usually backfires. It takes your attention away. It makes you more. You have to like. I love yoga. I love the Zen. I like what comes from your part. That you have to center yourself and pay attention to what matters. But let's make no mistake, as a surgeon who does it, we all have been in that situation that we're trying to take care of a patient and somebody else in the OR turn it all about themselves as you just described. But I love what you just said, that when you came back to India, they thought it's something wrong with you that after
They still do. This thank you is stuck into my head.
yeah.
Imagine second day of your fellowship, you've been just told that you're rude because you didn't say thank you about every damn instrument you asked from the sister. Oh my goodness. And that's a norm.
Well, this has been extremely eye-opening for me to see that even though I crossed these borders and so on,
Yeah.
At the end of the day, our life is so similar, your life and my life. Now,
Yes.
I'm hoping for this to be a continuous conversation, but I really thank you, Dr. Sharma, to be with me on this podcast to show, not the emergency room show or movie and so on, but the reality of being a surgeon, being a spine surgeon, and what keeps us going. So I'm really thankful for your contribution and your participation in this podcast.
Thank you for having us, sir. And it's always great to talk to you. We have less fellows who are doing such a noble job, and you're actually not being a surgeon. You're actually educating the whole world about how to do it right, how to do it fast. And by all of that, you're only trying to help the guy who's lying down on the table.
Well, I thank you, and I think as well your work is, I'm following that very closely. I'm really a big fan of you as well. And hopefully within a week, we are going to see each other in India, in Mumbai. And
Beautiful.
hopefully we can do a podcast then about the deep and fantastic history of India. I'm really looking forward to that.
Perfect. We'll do that. Thank you, Dr. Basi. Thank you.
Thank you very much. You have a good day. And for our viewers, this is the essence of medicine, the stories from spine surgery. And thank you for